I'm Dr. Srini Edaklon, Chairman of Scientific Committee of Kerala Society of Ophthalmic Surgeons. The Scientific Committee of Kerala Society of Ophthalmic Surgeons has started a new series, Innovations in Surgical Techniques. We started with Dr. Neto Rosatali from Brazil, who is probably the highest volume phacosurgeon in the world at present. And so that became a very popular program with more than 2,000 people watching. So when I thought about the next in that program, it was Pradeep Sharma sir and no one else whom I had in my mind. I actually had asked sir to have this program before the AOC. Then sir said, no, Srini will have it after. I got out of the stress and strain of organizing AOC. Then I asked sir if he can spare some time for us, and we readily agreed. And sir was my teacher in RP Center, where he was a professor and head of Strabismus, pediatric ophthalmology and neuro-ophthalmology. After retiring, he is now in Center for Sight, Delhi. And see, everyone, even the most of junior PGs would be knowing Pradeep Sharma sir, because he is the best teacher of squint neuro-ophthalmology and everything in India at present. And everyone, all these PGs would have definitely read his book, Strabismus Simplified, and he has simplified surgery so much that you can call it a Gita or Bible or whatever of Strabismus surgery for all these youngsters and even the seniors also. And sir was the first Asian to be invited to deliver the NAB Memorial Lecture by AAPOS in Vancouver, Canada. And Dr. I have with me the senior ophthalmologists from Kerala in the panel who will be discussing these surgical techniques after sir finishes his presentation. Have Dr. Elizabeth Joseph, Dr. Laila Mohan, Dr. Sadish Thomas, Dr. Nirmal, and Dr. Kavita from Shankara will also be joining us. And I hand over the stage to Dr. Elizabeth to take over and carry on with the proceedings. Ma'am.
Okay. Good evening, everyone. I'm extremely honored to become a panelist in this lecture by Professor Pradeep Sharma sir. Sir is very well known and highly reputed in all strabismus circles worldwide, nationally and internationally. And he's the only Asian to get this NAP lecture by APOS. He's very dear to all of us. He was the president of Strabismus and Pediatric Ophthalmology Society of India. I was a member of this society for a long time. And actually, SPOSI Society has taught me many strabismus principles. And that is where I got a good outlook on strabismus. Professor Pradeep Sharma sir has decorated many other official posts in addition to SPOSI. He has been he has chaired many conferences. He has more than 200 scientific articles to his credit. He is a reviewer of American Academy of Ophthalmology journal, JAPOS, Strabismus. And as Srini said, his book on Strabismus Simplified is quite marvelous.
I think you got muted.
New strabismus procedures, and we are eagerly waiting to hear your words of experience and wisdom. Over to you, sir.
Thank you, Dr. Elizabeth. Thank you, Dr. Srini. Thank you, ma'am, Dr. Laila, Dr. Satish, and Nirmal. It will be really a pleasure to be presenting some things which are not totally new or innovations, But those are the things which are changing the strabismus scenario that we are having at this moment. So one by one, let's have some, and then we'll discuss those. Kerala, as I said, it's always a pleasure to be, because the Strabismus Simplified book was launched in Kerala in 99, as you are seeing that, and that's why it is done so well, I think. It's the it's the grace of God in the God's own country where things work. So, and also my Rangachari Award also I got in 1984 in Kerala in Trivandrum. So we are going to talk about the newer techniques. The first thing that I would always like to say is that we have to understand this fact. Is it all right? Yeah. So the strabismus surgery has been changing over the period of times, and we have to now understand that our goalpost is nerve stereopsis. So this is one change or innovation that we have to bring in our mindset, that binocular vision and stereopsis is what we are going to aim. Just we don't talk about 20/20 vision as an ophthalmologist as the end point, but the stereopsis. We are not just treating strabismus, but restoring binocular vision and stereopsis. Now, this chart that we are seeing in front of us, a newborn child may be having straight eyes, start turning in at 3 months of age. We give glasses, we find that he's not fully corrected, so surgery has to be done. This is the case story of Dr. Ken Wright's son. He himself was bold enough to operate at 6 months of age and so bestow the stereopsis. This is what is important. I also realized when I was the SPOSI president that there was a lot of problem, and still there is, that insurance coverage for strabismus was not being given, considering squint as cosmetic and not congenital. So I tried to get the redressal from PMO, and I think it has helped to some extent. We need to remember that critical periods are important. For squint, it's 6 months, just like 6 weeks for congenital cataract and 6 years for most of the other refractive problems or intermittent exotropia. Timing is everything. So when we are going to talk of the strategies, we are going to focus not just on surgery, but we also remember that first we need to do a proper examination. I won't go into the details of that, but keep in mind that we have to have a good observation, confirm the problem, infer, plan, and execute. Now, even a child who is having a cerebral palsy can see the smiling face of both the mother and the child after the eyes get aligned. So we need to remember all the 9 positions and the fundus, which is showing you torsion at times, and the surgical procedures that are there. We know that it may be the recession or a hangback recession or a retroequital myopexy or marginal myotomy, different combinations of this, and they're adjustable at times. And in strengthening procedures, we have had resections, but now the plication, the advancement at times, and transposition of muscles. Surgical instruments, we all know, are very simple tools in strabismus, but the most important tool is, of course, our thinking process, which is required because we are going to deal with simple things, but in a programmed manner. There are several incisions. Some new incisions have come up, but they do not really serve the purpose. So the age-old was the Jamison's over the muscle, which we have now given up. Fornix incision parks is the mainstay for most of our planned surgery. But sometimes when there are the resurgeries or when we want to train the beginners, we say that we should be going for the limbal incision. And the miss that I was saying is new procedure. Actually, I would say that it's not so something that we are so much going to be enamored about, because as the author himself has said, it is a difficult process to learn. You have to do a transconjunctival suturing, the TRASU. It's a very deep learning curve, and it really doesn't serve us well. And what I would say is mostly we will manage with Fornix incisions, as this short video can show us to start with, that we are sitting on the temporal side, we are facing the muscle, anchoring the limbal suture, and then making a small incision. Then the Jamison's hook is being passed to hold the lateral rectus, and then the muscle is exposed neatly. It's important that we are keeping the muscle intact, and the pole is examined at this time so that we do not cause any damage to the muscle fibers, and the full muscle has to be taken into our hook. Now see this, the pole test that yes, the whole muscle is there and intact. And then we can separate the intramuscular septum, the check ligaments, pass the 6-0 vicryl sutures, and do our required recession procedure. It's important that full thickness bites are taken in the muscle, 6-0 vicryl sutures, and nicely imbricating the muscle. So these are common steps which we will see that we cannot miss. And even in the other innovations that we are going to talk of are going to be there. So these and then we can do the cautery for the bleeding, which is there. Marking is important, that because whatever we are planning, it's all in a mathematical format that we are going to use in a programmed manner. So the landmark is very important. The point which you are holding, being held by the forceps, is going to be displaced by up to 2 millimeters. So never mark from that same point. And partial thickness bites are taken in the sclera. So these are spatulated needles which prevent the perforation of the globe. Especially the myopic eyes, we will find, are very, very difficult to manage, and we have to be extra careful that we do not perforate. And then finally, we can suture these muscles. The plication is the procedure for which has replaced now the resection. And for the medial rectus particularly, I am doing most of the cases, maybe 95% of my resections have changed to plications. Now, plication is a very simple procedure. It is same way that we are going to hook the muscle, the medial rectus here, exposing the muscle, the intramuscular septum is separated on either side, just like we did for recession. And now another hook is passed, mark is placed. Even if you do not have the marking system, doesn't matter. You can directly pass the needle with the calipers being placed there. And the 6-0 vicryl sutures are passed. Now, this is a very elegant technique of reinforced plication that I have been talking about, that we will fold the muscle on using the iris depositor. So these sutures have been passed in the muscle. Now we'll pass the just in front of the muscle and then again in the muscle. So muscle, sclera, muscle. Remember this MSM. Now this is very important, that we are going to have a neat folding, and it usually prevents the regression of the effect. So it's folded on the iris depositor, and you will then tighten the sutures. It's important that we do not have slippage at this point, otherwise it will undo the effect of plication. Plication, as I said, is a very good procedure. It takes care of the problem in the sense that what you have in resection, that you will be sacrificing the blood supply, and also the risk of slippage is not there with plication. So we had compared resection and plication, and this is what you can see pre-op and post-op plication. 1 week post-op after the resection in the top two pictures and is of resection, and the 1 month post-op is of the plication bottom. You can see initially there will be some redness in the plication on the left-hand side, you can see, but then finally the right-hand side plication is showing you that it is quite neatly there. Because there will be no resection, there won't be so much of metabolic factors also. The advantage of plication is early reversibility is possible. Sometimes we have had overcorrection in resections. The problem is what to do. You'll have to pass sutures again. In plication, many a times we can get across by just doing the cutting of the sutures. And if you can do this, you can do it up to 1 week easily when the adhesions are not much. Maximum I have done is 2 weeks later plication, that I have had to go back and do a weakening of or under correction of the plication procedure. We recently in APOS 2023, I had been there to present on the inferior rectus plication for DVD procedures, in addition to the superior rectus recession, which we had another technique. And as you can see, we find that the inferior rectus plication of 5 to 5.5 millimeters can give you an effect of 14 prisms, 14.69 prisms in these 16 cases which we had in that study. And in SR recession of DVD, it was comparatively 17.46, which is more than the plication. But plication gives you the advantage of not disturbing the blood supply, and it can be the first primary procedure. So these are the pre-operative picture of a case in which DVD is there. Now, this is another procedure that we have sometimes done for superrectus recession with Y-split. Now, here is a case of DVD, and this is superrectus recession with Y-split. This is a technique which was told to me by Dr. Borgen from Germany while I was in a conference. And I think it was not very much popularized, and it's very few people have probably talked about it earlier. And I could not find any publication also. So we had done a small study to see the effect of it. And you see here the superrectus recession with Y-split being done. So the superrectus, you can see here, has been held on the either side. The intermuscular septum is incised, and now just like we do the lateral rectus Y-split, it is separated into two equal halves along the fiber direction and sparing the superior oblique, which is just underneath. And then the 6-0 Weichel sutures are passed. The superrectus halves are disinserted. So, I'm sorry, there's some issue. Yeah, so the cautery is done. And now the marking is done from the two ends of the superior rectus and then on the either side. So you have a separation of almost 22 millimeters. Just like for the Duane's retraction syndrome, we need to separate the two ends very nicely. The Y-split does an effect like a Farden or posterior fixation and weakens the superior rectus more than what you would get by a superior rectus recession alone. So even with a 5.5 millimeter of superior rectus recession with the Y-split, you may get an effect which is as much as superior rectus recession with a Farden, and it's much easier than a Farden. It also spares us from the problem of the superior oblique being there, and which may not be affected if you are doing a Farden procedure. So here you see this is the superior rectus Y-split, and now the conjunctiva is closed. This is pre-op case of DVD. See here, and the post-op after the superior rectus recession with a Y-split. Sometimes we have a procedure to be done, and I recollect Dr. Elizabeth talking about some of these procedures, the mini tenotomies, the mini plication. So mini plication, which was being talked about by Kenneth Wright, I have had a chance to do in some cases to correct small deviations. Like if there is about 8 to 10 prisms of deviation, like in this girl, you can see here, there is a DVD in the left eye. Asymmetric DVDs, particularly the eye which has a lesser DVD, you may not do a full plication, you may do a mini plication. Now, you can see that the left eye is having a hypertropia. And after the mini plication, as described by Kenneth Wright, 5 millimeters away, you pass the sutures and a single suture bite is taken in the to tighten the inferior rectus. So inferior rectus mini plication, you can see the effect is pretty good to correct for asymmetric DVDs or small hypertropias. Mini tenotomy is another procedure which can be done under topical anesthesia, transconjunctival grasp of central muscle tendon. Dr. Kenneth Wright has described this procedure to correct about 2 to 4 prism diopters. Somehow I have not been able to do this because I am not much enamored by a change of 2 to 4 prism diopters and doing a surgery. So I've never got a chance to test this procedure. Adjustable surgeries, you can see here 2-stage surgery we do a single stage adjustable surgery as we had described along with Dr. Renick in 2003. It can be done for recessions, adjustable resections, and also an adjustable Farden or the Scott procedure. So that is something which we will talk about. But first is the different strokes in adjustable surgery. We need to learn this process because you may require to do adjustable surgeries. Majority of the cases we do a conventional recession, but sometimes cases which are more demanding, like I will just share some, we may do an adjustable procedure. So here the spatulated needles are passed radially rather than circumferentially, and 2 bites are taken, and you need to have a room for adjustment. The sutures can be pulled up or recessed, and the 1.5 knot is taken for the vicryl, which will be released at 5 to 6 hours later. I prefer to do an adjustment 5 to 6 hours. And the pearl here is that we should avoid using bupivacaine at the time of anesthesia because of the effect being longer with bupivacaine. So just use xylocaine or lignocaine for the peribulbar block in such cases. And then 5 to 6 hours later, you can adjust easily. An anchoring buccal handle suture has been described by Dr. Rosenbaum, from whom I learned this technique. And it is very handy to hold the globe at that time of adjustment. So these are small differences that we'll see in adjustable techniques. Now, in this individual who had an abducens palsy with a bitemporal hemianopia. Now, this results in a situation that as long as the eye is having an esotropia, the hemianopia is taking care, and so there is no diplopia. But the moment you want to correct the esotropia and the eyes are little overcorrected, there will be double vision because of the eyes coming in that. So you have to be very accurate in your adjustment or surgery. So here we chose to do a adjustable procedure on the medial rectus recession, which was initially done 6 millimeters, but then we found we had to adjust or advance it forwards to 3.5 millimeters, and we could resolve the problem of diplopia. So adjustable procedure in such cases can be very handy. So one should keep a note of that. You may use either a hemi hangback or a full hangback. You may use a sliding noose, or you may use a 1.5 knot. Just like COVID times have shown us that both sliding noose or a 1.5 knot can be used for the mask. Same is true for adjustable sutures. Divergence access problems. That means the disparity is there for distance and near. The deviations are more for distance and less for near, a true divergence access. Such situations create a dilemma that if you correct for near, you will have a residual exo for distance. If you correct for distance, you will have a consecutive ESO for near. So such cases require to be handled differently. So near distance disparity, if there is a convergence access esotropias, we usually add a Farden suture on the medial rectus. But for exotropias, the Farden on the lateral rectus doesn't work well. And so we have found that you can create the Scott procedure for this kind of surgery, a combined resection and recession on the lateral rectus for divergence access XTs. Now here there is a pre-op and the post-op. You can see the disparity has been corrected. And here the co-author, Dr. Bhaskaran, she's again from Kerala, and this is the procedure that we're talking about, the combined resection recession procedure on the lateral rectus, the Scott's procedure. So what we are doing is things are similar as we talked about in the initial picture. The lateral rectus here is being hooked. We are now marking the resection. Remember here the resection and recession is being done on the same muscle. So we have marked the resection point. This part will be resected. And then I am passing the sutures. So remember, we are going to resect the muscle and then recess the same muscle. So this is Scott's procedure. If you do the same amount of resection and recession, then it becomes a adjustable Farden, or what has been described as by Ellen Scott. But if you do a variable amount of resection and recession, that means X plus Y is the amount of recession and X is the amount of resection. Now here we plan, let's say, a 4 millimeter of resection and 8 millimeter of recession. It will give us a correction for 4 millimeters in the primary position, and the other 4 millimeters will give us the lateral incomitance in order to correct the excess exotropia for distance. So this is another nice procedure which comes handy for near distance disparities, the Scott procedure. Now, this lady who had a right residual third nerve palsy, and I had to do a lateral incomitance correction. As you can see, the 9 gauges, it's 8 prisms, 16 prisms, 35 prisms. So if you want to correct that, what do? You can do in the good eye, the lateral rectus recession, which I did Scott procedure. So combo resection 6 millimeter plus recession 12. So it is a half x is 6 and x plus y is equal to 12. So this is going to give rise to a better correction for the distance disparity or the lateral incompetence. Coming to the obliques, I have been a strong votary of avoiding inferior oblique myectomies and free superior oblique tenotomies. We talk about inferior oblique overactions and they can be variable. There can be 1 plus, 2 plus, 3 plus, 4 plus inferior oblique overactions, and in the two eyes it may be different overactions. So we need to have a different surgical procedure for according to the sizing. Just like when we go to a mall, you want to have a proper size, whether it is extra short, shorts, medium or large or XL. One size doesn't fit all. So you need to have a proper sizing to correct. Myectomy would not serve the purpose. Whereas if you have different procedures, recessions with anterior positionings, the Finks, the Parkes procedure, the Elliott and Nankin procedure, or the modified Elliott-Nankin procedure, or the anterior nasal transpositioning. So different procedures. The right hand side shows a diagram from my book, which is showing you the inferior temporal quadrant of the globe and the inferior oblique running across. If you go along the course of the inferior oblique, you will do a pure recession like Finks. If you slightly advance it, anterior position it, then it becomes a Parkes procedure. If you do a full advancement, a total anterior positioning, if you do a modified Elliott and Nankin, like we do for most of the inferior oblique overactions, and then of course the anterior nasal transpositioning. So this is the pure recession. This is the Elliott and Nankin anterior positioning. Here, remember, this neurovascular bundle of the inferior oblique turns the temporal or distal part of the inferior oblique into a anti-elevator. Now, mind you, this is not a depressor. Inferior oblique can never become a depressor, but it will become an anti-elevator because the innervation will come during elevation and it will prevent the globe from turning up. So this is a very good procedure for DVDs with overaction. If there is a DVD with inferior oblique overaction, the choice procedure is inferior oblique, Elliott and Nankin total anterior positioning. It will correct the inferior oblique overaction as well as correct the DVD by this procedure. But never do this procedure in a person not having inferior oblique overaction. So inferior obliques, as we see, we have different options. We usually do a modified Elliott and Nankin procedure, as I show you here, because we do not want too much of anti-elevation. Then we can do a modified Elliott and Nankin procedure. The lateral rectus being hooked here. And now the inferior oblique is being hooked directly with the two hooks technique. And now you can see the white triangle posteriorly that shows that the entire inferior oblique fibers are in your hook. This is important because otherwise you may split the inferior oblique and then have a residual overaction. Disinsert the inferior oblique and then pass the sutures, the 6-0 vicryl sutures. Now, once you have done this, you can do any procedure of inferior oblique from Finks to Parkes to total anterior positioning to the modified Elliott-Nankin as shown here. In the modified Elliott-Nankin, what I'm showing is that one suture is passed close to the temporal border of the inferior rectus and the other one is passed along the border of the temporal border of the inferior rectus. And then the sutures are tightened. But in the stages anterior nasal transposition, the muscle is brought on the nasal side. And this becomes a very good procedure for 3+, 4+ inferior oblique overactions. Now here I'm showing you a video of this inferior oblique anterior nasal transposition. In this APOS conference, I had a chance to present this to the audience there for controlling the torsion by using inferior oblique. In a symposium there, the inferior oblique is now being hooked. The same way as I've shown you for the modified Elliott-Nankin, but ensure that all the fibers are in your hook. Then disinsert the inferior oblique. After cutting the intermuscular septum here between the LR and the inferior oblique, all the fibers are disinserted of the inferior oblique, and then the sutures, 6-0 vicryl sutures are passed. So this was common to what I showed you earlier for modified Elliott and Nankin procedure. Right? Now the change is here. Now you hook the inferior rectus, first Jamison's and then the Green's hook. Take out the Jamison's hook. They expose the inferior rectus muscle using the lens hook. And the nasal to the inferior rectus, the intermuscular septum is incised. And the inferior oblique is now brought on the nasal side. So what you need to do is a little bit of dissection to separate the intermuscular septum or the check ligaments of the inferior oblique. And now 2 millimeters posterior nasal and 2 millimeters posterior to the inferior rectus insertion, the bites are taken. Now this position prevents anti-elevation. So you tighten the inferior oblique here, and you will get a correction of the inferior oblique overaction up to 3+ or 4+. So this is a very good procedure for very severe overactions of inferior oblique. Now we have a fundus extorsion, which can be corrected by the proper inferior oblique surgery. And this case, which has a ortho in primary position, an exo in up gaze, and ezo in down gaze, a pure V pattern with bilateral inferior oblique overactions after the inferior oblique surgery, can be corrected ortho in all the gazes, and as well as the elevation in adduction is also corrected. Coming to superior oblique, it's a very delicate muscle. There are various procedures which have been described, right from tenotomy, tenectomy, Z or L tenotomies, PTSO or posterior tenotomy, anterior tenectomy, hang loose loop tenotomies, silicone expanders, recession, translational recessions, differential recession of interior fibers, and even the retroplacement of trochlea. So as I have crossed the tenotomies and tenectomies, which are usually not done, and Z or L tenotomy you may do sometimes. PTSO is a good procedure for mild to moderate superior oblique overactions, and the little tighter superior obliques like Brown syndrome, you may do either a silicone expander, or still better is to do a hang loose loop tenotomy. Or very severe ones, you may do a translational recession. Now, these are the weakening procedures shown diagrammatically, the PTSO. And here is a video of the posterior tenectomy of the superior oblique. The superior rectus is being hooked. The superior oblique is also hooked in the other hook. And the anterior fibers are marked and separated. You go nasal when the tendon of the superior oblique becomes narrower. And you can easily go to the posterior limit of the superior oblique and incise these fibers. And then the triangle or the trapezoid of these fibers is brought, and then it's cut. So it's a very simple procedure, but yeah, you have to be requiring good assistance in this procedure because the vortex veins are closed. Both the vortex veins are there at the superior oblique insertion. You have to be very, very careful. You don't need any sutures in this, but you have to be very extra careful for preventing any bleeding. Now here, this child having an A pattern exotropia, a bilateral PTSO was done along with the little rectus recession, and you can see the correction is being made. The translational recession is for severe procedures, and the expanders are also described, but we have stopped doing superior oblique expanders nowadays because it results in a lot of problems. It's a little more difficult procedure, and later on you have something left in the orbit which may create problems. So I usually find instead of the expander, I would rather do a loop tenotomy as shown in this. So this individual is having a Brown syndrome, and left eye, one can see the superior oblique is moving nicely to the abduction, but adduction was not, elevation was not there. So temporally, superior temporal incision is made. The superior oblique is now being hooked. The intermuscular septum in front is separated. Now the superior oblique is disinserted. Full width of superior oblique disinsertion should be done. All the fibers are incised, and one can check by doing a force reduction test at this moment. Here, non-absorbable sutures, the 5,0 ethibond is used. And now you see the FDT being done to see that we have indeed taken care of the tightness of the superior oblique. Now, this is like a adjustable hangback, and you can do 10 millimeters and then check the FDT. So whatever desired lengthening is required temporally, the superior oblique is being lengthened temporarily here, and one can check that the FDT is free, and then you can close. So this is giving us the desired amount of weakening of the superior oblique without having a risk of superior oblique palsy. For strengthening, there are several procedures on superior oblique. The age-old procedures have been tucking, the Harada Ito and the modified Harada Ito. So these, I think I may not go into the details, just to summarize that we have these procedures. But bilateral superior oblique palsies and bilateral Harada Ito is a procedure of choice. So this is a short video of the Harada Ito procedure, in which one may do an adjustable in one eye. So superior rectus being hooked. The superior oblique is identified here. As you can see, these shining fibers, and then the superior oblique is dissected. Only the anterior fibers have been separated, half width of the superior oblique fibers. You can use either a 5,0 ethibond or a 6,0 vicryl also is fine, if because you are going to advance these fibers. Now, these are advanced 8 millimeters close to the lateral rectus, 8 millimeters from the insertion of the lateral rectus. Recently, in the APOS conference, Dr. Holmes was suggesting that instead of doing an advancement, he is suggesting doing a resection of this part of the superior oblique. So here we are doing an adjustable Harada Ito. This can be adjusted 5 hours from the surgery, and then you can see the endpoint of torsion corrected. So the transposition procedures have evolved in several ways, and there are so many in our plate of transposition, right from a partial tendon VRT, the Hammersheim procedure, the full tendon VRT, single muscle SRT or IRT, and then augmenting the resection by augmenting the transposition by resecting part of the VRT, augmentation by Foster sutures, or augmentation by cross-section sutures. The cross-section suture is something which is we have been talking about from some time, because it has the advantage of adjustment and without causing any problem. So this is something which we can do if we are not doing a Nishida's procedure. And this I had presented in 2015 New Orleans APOS as a procedure for a lateral. So here in the lateral rectus palsy, the VRT has been done as a cross-section partial VRT with the MR being recessed. MR we need to recess if the tight FDT is there. And you can see how the improvement in abduction has happened after the VRT, a cross-section vertical rectus transposition. So what has been done is the temporal halves of the superior and the inferior rectus have been cross-sected, and they have brought the inferior half comes at the upper pole of the lateral rectus, and the superior half comes closer to the lower pole of the lateral rectus. We are not disinserting the lateral rectus because we want to keep the blood supply intact. Modified Nishida's procedure is again a very useful procedure. No disinsertion, no splitting, no risk of anti-segment ischemia. Directly, we vectorize the force to the sclera by non-absorbable sutures. So there is no lax middleman. It's like direct bank transfer. And unlike the Jensen's procedure, in which the vector force is transmitted through a paralyzed lateral rectus muscle, and it doesn't give us the lasting results. So this is a very good procedure which can be done, the Nishida procedure. So in case in which you do not have a muscle, like in this case, medial rectus was slipped. So the superior rectus, non-absorbable 5,0 ethibond sutures 8 millimeters from the insertion are passed. So you imbricate the muscle nicely, separate the intermuscular septum to free the muscle which you want to vectorize this way. Otherwise, it will not yield the results. And then at the sclera, you will pass the sutures and then back into the muscle sclera muscle. Here the bites are taken, and this will vectorize the force. So you may do both the SR superior and the inferior rectus Nishidas, or you may do only one of them also at times. You may do an inferior, as we nowadays call, instead of Nishida, a belly transfer muscle belly transfer procedure. So the force can be vectorized. So in cases of Duane's retraction syndrome, this is a very useful procedure that we can do. Or in sixth nerve palsies, this can be done. Now in ESO-DRS, when we have done both medial and lateral rectus, and we want to increase the abduction, we cannot do a SRT because the risk of anti-segment ischemia. So in such cases, Nishidas is a good procedure. So you can add a modified Nishida to improve the abduction. Remember, anti-segment blood supply is going to be affected if more than 2 recti muscles are handled in the same eye. So we have vessel sparing surgeries described, but the modified Nishida is a good procedure to take care. Or you may use a cross-section partial VRT, where we are sparing the other halves of the blood supply. Finally, the myopic strabismus fixus is a procedure which we'll talk about. Here we know that it is not a real palsy, but it is the loss of position of the superior rectus and the lateral rectus which has caused this muscle. This was nicely described by Yokoyama, that the muscles are actually displaced from their positions. So a coronal CT taken in these myopes, you can see how the lateral rectus is in the lower quadrant. The superior rectus has come on the nasal side. In fact, the superior, the inferior, and the middle rectus are on the nasal side of the orbit, and only the lateral rectus is left alone. So it also migrates downwards. So there is no abduction force. That's why there is a severe esotropia. If this is so, you may do a procedure which we call as the superior rectus lateral rectus myopexy procedure, or the Yokoyama, modified Yokoyama procedure. You may do an MR recession if the MR is tight. So this is a case, the same case which we had initially, and you can see how nicely that gets corrected. So myopic strabismus SR-LR loop myopexy, here is the procedure that I'm now talking about. Here you see the superior rectus being hooked, Jamison's hook, and then the Green's hook. And on the nasal side, the intermuscular septum is dissected to free it. And just like the Nishidas, 50 ethibond sutures are passed 8 mm from the insertion. So what Yokoyama described is much posterior, 14, 16 mm. I see that even 8 mm suffices. So one can make the procedure simpler and transpose the superior rectus. You may take it full width and bring it closer to the superiotemporal quadrant. Here the lateral rectus is also similarly 8 mm away. The ethibond sutures are passed. And in between the sclera, the bites are taken. So both these ethibond sutures from the lateral rectus and the superior rectus are then tied together, crossing over to each other, and that causes a loop myopexy of the SR-LR. And you will find them that now we are repositioning the lateral rectus as well as the superior rectus in their true positions, and without any resection of the lateral rectus, the esotropia can be corrected. So see how these two sutures have now been tied together. The incision was fornix incision, the superiotemporal fornix incision, and these sutures are tightened. So you can get a very good results of myopia being corrected. Third nerve palsy is a real difficult situation. There are several procedures. I will just hint them. We may do, in very severe cases, a periosteal anchoring. But more recently, in several of these cases, we are doing a nasal transposition of the split LR. This is a case in which this nasal transposition of split LR has been done. So this is also a very good procedure for synergistic divergence cases in which we can correct these. So finally, I would like to bring an end to my talk here. Targeted strabismus surgery. So these cases which are having misinnervations, you can identify the problem and correct the problem, like in myopia cases, myopic strabismus, or in synergistic divergence, or in cases of the synergistic innervational downshoot, which we described in this case, in which the inferior rectus has been repositioned. What more in strabismus surgery? I think Dr. Nirmal was asking, lots are still going to happen. Superior oblique tendon sheet stripping has been described by Welles recently. Repair of the inferior rectus flap tears by Ludwig. Muscle transplantations have been described, we have done, but we don't find it very exciting. Anterior tendectomy of superior oblique, resections of the interior SO fibers by Holmes in place of Harada Ito. Sinskis procedure for nystagmus, again, not a procedure of choice. So for nystagmus, I would say the augmented Anderson's procedure is very good for 30 degrees of face turns, and for more, you may add resections. So I would like to end my talk here that you need to be a squintellectual, and you can restore the alignment and restore the binocular vision of an individual. And so as a strabismus surgeon, we can be doing a lot of challenging cases. We are not just treating strabismus, but restoring binocular vision and stereopsis. Thank you very much for a patient listening. We can all work together, and I would like to thank my parents, my wife, all my colleagues, the residents and fellows at both the places at AIMS as well as Center for Sight. Thank you so much.
Thank you, sir. It was a wonderful presentation as is expected from you, sir. So, Elizabeth, ma'am.
Yeah, sir, it was a very informative talk. In order to go ahead with some questions, I will ask some questions, but I don't know whether it is relevant or not. So what is your opinion about fully posterior fixation for convergence excess? You didn't mention about that. You are against that, or?
Yeah, I have heard about it. I have seen that. Somehow I am not very much convinced about it. Some people do it. I had seen Dr. Deemer doing when I was doing my fellowship in UCLA. And I have seen from Australia, there were some papers being published. I don't know if you are also doing. Somehow what I feel is that you are tying to the pulley. It may...
Pulley to the muscle.
Yeah, the pulley. So basically, I don't know how much
tightening it to the...
there. Yeah, and how long the effect lasts.
See,
I haven't done much, so I don't have much experience on the pulley.
Say in convergence excess esotropia, where the angle of deviation is more for near and very little for distance. When you do MR recession, we have to do Faden in addition, no? Otherwise, so Faden is a bit difficult to get this scleral switches. So I have tried this surgery. This has given good results to me, but I don't know whether the pulley works or just like that. I don't know.
Yeah.
No, it must be working. Yeah, Dr. Leila?
When Demer proposed this pulley concept, and as Dr. Elizabeth was saying, I found I had done quite a number of partially accommodative esotropia, and also where there is near distant disparity. Instead of Faden, I had switched to almost switched to pulley fixation. They do well immediate post-op, but over a long-term follow-up, I have seen that it wears off, and then again some residual ESO is seen for near. So nowadays, I don't do pulley fixation anymore. I had done quite a number of them during the initial, probably in the late 2000, that period when pulley fixation, pulley concept was more, yes.
So that's what my apprehension was. But I think if you find Faden a little difficult, another procedure there you can try is the Scott procedure on medial rectus. Okay.
Means
on the medial rectus
procedure means by splitting.
Combined resection. No. Combined resection.
Oh, combined
Scott procedure. So that's what I had shown for lateral rectus. For medial rectus also people have tried, and they have found that you don't have to go that far in that case. So for example, you want to have an effect in these, I mean, Scott procedure medial rectus, I have tried only in a very few cases, because I have been more, happy with the Farden, and I don't find it as difficult. I would usually do a recession with a Farden. But yes, I would say that, yes, you can try a Scott procedure. So you would do a resection of the medial rectus. Let's say you do a 4 millimeter resection, and then do a 6 or 8 millimeter of this. It will create a 4 millimeter recession effect for the primary position, and it will give you the convergence axis correction by the 4 millimeter effect. That is in theory I'm talking. So this will affect, but so Scott procedure on the medial rectus can be an alternative for a near disparity. That means convergence axis for medial rectus if you want to do. Because on lateral rectus it works, whereas the Farden doesn't work well on the lateral rectus. So I'm sure it will work. The same has been done for the inferior rectus. Some people have done the Scott procedure on the inferior rectus for cases in which they do not want to do too much of inferior rectus recession. So you can do a recess procedure on the IR. It will have less of inferior rectus recession to be done, and you will get the disparity corrected. But these need to be tried. Yeah, these can be as another coming up alternative as Scott procedure.
Sir, you mentioned using the inferior rectus plication for DVD without inferior oblique overaction.
Correct.
It's like you have completely switched to inferior rectus plication in such cases, or?
No. So those cases, as you have rightly said, first of all, we should see that there is an inferior oblique overaction or not. If there is an inferior oblique overaction which is significant, the procedure of choice is total interpositioning, because you will correct both the problems, the V pattern, the inferior oblique overaction, as well as the DVD. But as you have said, cases which do not have an inferior oblique overaction. So those cases, nowadays, our primary choice is IR plication.
Okay.
So earlier we were doing superior rectus recessions for these cases. So I would say now we can first do a IR plication, and most cases, as we saw in this comparative study, the numbers were a little less because of this was done during COVID. So we could not do more than that number, but we found that it gave us very good results in the, it gives you the anti-elevation effect. Best part is that you can undo it, and you can overdo it if you want to. You can again visit it and do it. So these procedures, which I generally say, have the razor with the eraser. Always have a razor which has an eraser behind it. Do a procedure which you can undo, which you can tailor. If you do a procedure which you cannot later on correct, then it is a lost case. So I think IR plication is now the first choice. But if you have to have, let's say, as a second procedure, then one can do a superior rectus recession with a Y split. Again, with the Y split, when we do, it is serving the same purpose as a Farden.
Okay.
By the way, Dr. Elizabeth, I mean, even this has been described by some workers from Eastern European country. I saw that MR recession with a Y split.
MR recession also.
MR recession with Y split in order to give a Farden effect. So this was described. I mean, this has been there, I think, almost 15 years back. I saw that article that MR recession with a Y split can be done. So just like Scott procedure. So these are alternatives to Farden. But many a time we prefer Farden because it is less traumatic to the muscle. When we do a Y split, it's a little more traumatizing to the muscle. You're splitting, you're causing bleeding and all that. Generally, we keep it as a last resort.
But as you have shown this Y split in superior rectus, I think instead of going behind the superior oblique, it's if it serves the purpose, I think it is a better choice than superior rectus Farden.
I don't know.
That is true. That's why I think I remember Dr. Andrea Molinari, I mean, when she was listening, she asked me to present it in the ISA. So in one of the monthly things, we had this presentation of the superior rectus recession with Y split for as an alternative correction for DVDs. So quite right, because then you limit the amount of recession required. You don't have to go 7 millimeters or 9 millimeters on the SR recession.
Sir, right now, What is your preferred choice for DVD without inferior oblique overaction? Is it inferior rectus plication or
Yeah, that's what,
SR
that's what I said.
Huh? That is the first
That's what I
choice.
said. The first choice would be IR plication.
IR plication, or will it produce a hypotropia in the primary position if you do an IR plication? Hypotropia in the primary position, will it produce?
But usually when you're doing these cases are manifest DVDs which have a hypertropia, isn't it? Because
Okay.
these are the cases which have a manifest hypertropia, then only we are operating. Had they been only a phoric, then we don't operate.
Okay.
And cases in which there is asymmetry, let's say there is a more DVD in the right side, you do the plication, and the left eye has a lesser DVD, then you can do a mini plication on the inferior rectus, which will have a lesser effect.
So there are some doubts in the YouTube. Samyukta is asking, sir, how do we plan the surgical dosage and plication procedures? And Dr. Akshay is asking, if overcorrection occurs after plication, till how many days can plication be reversed?
Okay, so I think as far as the dose is concerned, we found that the same dose as you do for resections will be sufficing. You don't have to change. So because we are passing the sutures at the same point as for resection, we find whatever surgical tables or dosage you have been doing for resection, let's say for an exotropia, you are doing, let's say 7 and 5, 7 lateral rectus and 5 medial rectus, you do the plication also 5. That is one thing. Second is, if you get a chance over correction, then what to do? We can trim the plication sutures. So that will undo the effect of plication. It usually will undo it not 100%, but maybe less. So you'll get a good correction. So you suppose you got a consecutive ESO after the surgery on the middle rectus plication, you trim the sutures. You can easily do it 24 hours, 48 hours. But at times it has been delayed. Like I remember one case, we were, contemplating whether to do or not, or it will become all right. Little overcorrection is fine. But that individual was not happy with the 10 prisms of overcorrection. So I had to do it at 2 weeks. And I found that adhesions do form. So after 1 week, there will be more and more adhesions. But you can do it and the effect will come even at 2 weeks. But then you have to do, after the trimming of the sutures, you should do a FDT, pass a hook and pull the middle rectus and the globe on the other side so that there is a separation of the plicated muscle. Beyond 2 weeks, I haven't done. So I don't know. Yes, Dr. Leela.
Yes, I have tried. As you said, contemplating on whether to redo or not. It went on till another up to 1 month, and I found it very, very difficult to undo because additions were so strong that I couldn't get a few millimeters out of it. But of course, after you traumatize the muscle if you try to pull it. So I had to leave it alone.
Yeah, so then it becomes like a resected case. So you will have to do a recession.
Yes.
Muscle, you can do it. Because usually, as I've seen that after a month, even the lump has become very much settled. There is not much of even redness. Some cases may have redness till about 1.5 to 2 months also. But mostly after plication, they are quiet. After a month.
So one more question, Dr. Surinder Kumar asks if there is no hypotropia in primary in DVD, will you still go for inferior rectus plication or superior rectus Faden or superior rectus Y split?
No, if there is no hypertropia, you mean, that's what.
The question is if there is no hypotropia in...
she means hypertropia. If there is a hypertropia, DVD, you will expect a hypertropia.
Hypertropia.
Yeah. But yes, if, as I said earlier, if there is no manifest hypertropia, then probably one may not operate. In DVD cases, we usually go by this, that if there is a phoric DVD, don't do anything. If there is an intermittent DVD, you try to use other measures, like, for example, you may do a non-surgical correction of the amblyopic eye can be made better, the vision becomes equalized, that intermittent becomes phoric. But if you have a case in which there is a manifest DVD, then I would suggest that you do an IR plication. If you are having a less of that, let's say only 10 prisms, then you do the mini plication. So that would be the other option. If you are in doubt, okay, you want to have some correction, but not an over correction, then you can do that.
Dr. Kavita wants to know about the role of neuroimaging. In what context, I'm not sure. Kavita is asking.
I think she may be talking about myopic strabismus cases. You need to do an imaging of these cases. A coronal CT is a must to know that the extraocular muscles are displaced, what we call as a lateral rectus dystopia. The hypo positioning of the lateral rectus in the inferotemporal quadrant, and the superior rectus are nasally positioned. So a coronal CT, if nothing else, it's not very costly. I mean, relatively, you can do a coronal CT, even if it's without contrast. So that can be done to know. So that is a very important thing. Neuroimaging is very helpful in cases in which you have misdirected cases like synergistic divergence or a synergistic innervational downshoot, which I had mentioned in my later part of my talk, that these cases you may do imaging, and here the imaging is going to be more specific. What we mean is that you will do a dynamic or a kinetic imaging, MRI, in which the pictures are taken with the person being told to look dextro gaze, levo gaze, and the primary position. So these are like specified thing, not easily done. You have to have a good rapport with your radiographer, or you have to be there yourself to see that you ask the person to look in these directions when these images are taken. Then you will have these gaze positions. What is happening to the extraocular muscles in different gazes? We call them as dynamic MRI or a kinetic MRI, and this will confirm your misdirected extraocular muscles. Then you can do a proper surgery for that.
Sir, in synergistic divergence, for some time you were doing periosteal fixation. Is the Y-split lateral rectus better?
It's ideal.
Will the muscle be too tight for pulling it towards the medial rectus?
I mean, that one can check how tight it is, but usually a little bit of tightness of lateral rectus doesn't create a problem with this nasal transposition, anti-SLR. What you may do is, at the time of repositioning on the nasal side, you recess the muscle. The lateral rectus, you can do an FDT at that time. If you find the lateral rectus was too tight, then you wouldn't position it close to the insertion of the medial rectus. You would recess it. So do an FDT at this point. So because, and this is also important in the anti-SLR, that you need to have a good split of the lateral rectus. And an FDT on the table should be done in order to prevent the collapsing of the veins around the optic nerve. We had one case in which there was the uveal effusion syndrome because of the, the two wings of the lateral rectus tightening around the optic nerve sheath or the vortex veins probably. So in such a situation, then we had to release these sutures. So what I say is that now we have learned that at the time of end of the surgery, you should do an FDT, see that the lateral rectus is not being too tight on the medial side. If it is too tight on the medial side, let it be recessed a little bit, so that you do not have a uveal effusion syndrome, one, and secondly, you do not have a too much of esotropia. We have also described that you can keep, if there is a cooperative patient, this on adjustable sutures. So you can adjust it at the after 5 or 6 hours, the nasal transposition of split lateral rectus.
Yes, lateral periosteal fixation, I have found the lateral rectus is still pulling the eye. I don't know how.
No, because of the attachments. So when we were doing the periosteal anchoring, I don't know if you did that or not. You should compartmentalize the lateral rectus. After the periosteal anchoring of the lateral rectus has been done, you did. So the tenons is sutured in between the lateral rectus and the globe, so that the adhesions do not form with the lateral rectus. Otherwise, some part of the lateral rectus will find a way to attach to the globe, and then it can do it. Yeah, I agree. That can happen.
Satish, any comments or queries from you?
Yeah, you are muted, I think.
Sir, see, there's one more query on the role of anti-segment OCT and UBM.
Yeah. So I think it's a very nice question. When I was in RPC, we had done a study. Dr. Amar Pujari is really a great hand on that. ASOCTs as well as UBM. UBM may not be that much useful, but ASOCT, we have seen in some cases can be of some worth. The problem is usually that they come in that blind area. About anterior to the pulley area or anterior to the equator, these areas are not very nicely captured. So we are not always going to get a very reliable information. But yes, ASOCT can be done as well as UBM can be done for these cases to know if there are slipped muscles or there are missing muscles. But sometimes you may still be surprised.
Laila ma'am, any more questions or comments?
I
No,
think
actually,
Nirmal was raising his hand. Yeah.
Yeah, Nirmal.
Yeah.
Go
Yeah,
ahead.
sir. Sir, what do you do in cases of blowout fracture? Recently, we had a child who had a wide blowout fracture, and the blowout was repaired. The mesh was also placed, but still he developed a hypertropia, left eye, in the left eye hypertropia. It was around 35% in the primary case with a -2 inferior rectus underaction. So it was an inferior rectus paresis, and he had a prominent chin down posture. So I ended up doing a modified Nishida on the lateral rectus and an inferior rectus plication. And my question specifically is, in such cases, do you need to do the Nishida on medial rectus as well as lateral rectus, or only on one would be enough to correct the hypertropia?
So generally, what we would do is that both should be symmetrically done. Unless you find that there is a depression, underaction is only in one direction. So if there's an asymmetry, because if you do, let's say, the lateral rectus alone, Nishida, you may have a little bit of incompetence also. So in order to balance the two forces, we would like to do Nishida on both medial and the lateral rectus so that the depression effect is enhanced and you do not have a shift only to the, otherwise there may be an exotropia which is created if you only do a Nishida on the lateral rectus.
So this idea was told to me by Sandra madam. She said to do the Nishida in such a way that you bring the inferior border of the lateral rectus 3 millimeters away from the lateral border of the inferior rectus, 8 millimeters from the insertion, and actually got a good correction, almost ortho in the primary, but the depression insufficiency still remained. Maybe my plication did not work well because of that. Anyway, his chin down posture.
No, your plication actually may not be working because the IR is not getting
paralyzed.
No, that was the problem. Underacting IR was there. So you are actually plicating a muscle which is not having innervation. So it's a partially dead muscle. Same happens with third nerve palsies. We end up doing MR plications of 8, 9 mm and still we do not get the results. So that may be the reason. But yes, you can do an IR belly transfer and lateral rectus belly transfer to the IR. It can work. But I don't know. I mean, there may be a little bit of exo maybe there. If you didn't get an exo, then it is fine. But yeah, these procedures are a little tricky. Even like NAPS procedure, sometimes we get surprised. We get an undue exo or ESO, although we have shifted it equally. So if you do only one muscle, probably you may have a little bit of exo, ESO created. So be prepared for that, or maybe you can keep an adjustable thing, then it's fine.
Sir, can you hear me now?
Yes, Satish.
Oh, yeah, thanks. Yeah. So my question is regarding the anteronasal transposition of the inferior oblique.
Yes.
When would you do that over a stage 2 anterior transposition? Is it when you want more effect than that, or for the egg?
So inferior oblique overaction of 3+, 4+, I would do an planned anterior nasal transposition. So sometimes, like for example, we have a V pattern, exo or ESO, and you have a asymmetric inferior oblique overaction. On one side, I have, let's say, 2+, and the other side is 3 plus inferior oblique overaction. So then I would do a modified Elliott Nankin on the 2 plus side, and the 3 plus I would do an anterior nasal inferior oblique transpositioning. So in order to give more effect on the eye, which is overacting more.
Okay.
So in stretched scars, when we get a long-term progressive residual ESO
Yes.
after BMR, like I don't know how much correction after going for the again re-advancement. There is a.
I know these are tricky. I really understand that these are problems. Some people, I don't know. We have had some situations that some of these cases have a stretch scar. Not all. Some develop it. Some have these. Either they have some problem with their collagen that these people have. The medial rectus particularly, it leads to a consecutive exo. And some of the times you have advanced the medial rectus and still you have a exo left. So, I mean, these are challenging situations. I remember, I think, doctor from Israel, he talks about using non-absorbable proline instead of Vicryl for medial rectus as a routine. Probably he is getting more of these cases of in their probably ethnic group. Maybe there is more of this problem of consecutive exo which is happening. So he is suggesting using the proline sutures for medial rectus. He says that probably Vicryl, there is a problem that it may have a stretch scar or a slippage, partial slippage that may be there. But yes, I have encountered some cases of consecutive exo after the medial rectus recessions, and we do it again, and still one case was in which, in spite of doing the medial rectus advancement, again there was a residual exo. He was a foreigner. So again, I feel that some of these people may be having some particular different collagen problems, healing process or whatever. So yes. So these cases, if you resurgery you're doing, use a non-absorbable suture.
So otherwise, for a routine inferior rectus plication also, you would use absorbable suture only or non-absorbable, sir?
I am using absorbable sutures for plications, inferior rectus as well as medial rectus. Vicryl only, 60 Vicryl.
So I don't know if Nirmal had already asked this.
IR recessions in thyroid cases, people have suggested if you're doing adjustable, use a 50 ethibond. Because recessions, there may be a problem. Yeah.
Yes. So for DRS, would you, if DRS without a face turn, to increase the abduction, would you do modified Nishida?
Yes. No, you mean ortho DRS.
Ortho DRS, yes.
Okay. So ortho DRS, first is you'll have to do something because they are having probably marked upshoots and downshoots.
No, not for that also. Just to increase the abduction.
Would
you do anything?
I would rather leave them. Ortho DRS again is a challenging problem. And unless they have marked upshoot, downshoots, then you have to operate on them. Then you do an adjustable MR and a lateral rectus vice plate. Because again, you are handling a situation in binocular vision is there, head is straight. If you end up having a little bit of incompetence, the patient is not going to be happy. So if you do let's say Nishida, you will improve abduction. In fact, one case in which I had done a Nishida for an exo DRS, his abduction improved. He was having a little more exo. He's not happy. He's saying that I'm again having a face turn. So these cases, I mean, you have to be a little more choosy that you may use your discretion.
Yeah.
So one thing, you have shown that letter from the Prime Minister allowing strabismus surgeries to give insurance. I don't have that letter. Can you share it or the number or something?
I think we have shared it several times on the.
But it's not. I cannot make it out. I saw the slide, but it's not clearly.
No, I can send you the copy of that PDF. I will send you.
Okay,
Sure.
thank
So
you.
Ayushman is providing
Yes.
insurance coverages there, but some of the companies, I don't know whether it is their policy that any
Many
congenital
insurance
abnormality.
companies are trying to still
Reject.
play the game because their executives are taught to reduce the claims. So they would play the game, and then we have to again and again do this. Then they agree. Sometimes they initially refuse, and then they will say, "Okay, we'll do it." Sometimes they put some other objections. Some have weird objections. Sometimes that no, this power is there. Nothing to do with power. Whatever optical power is there, that's nothing to do with the strabismus. But they have such, excuses. But we need to work on the other issue now that the claim given is much less in the Ayushman as well as the other insurances also sometimes by states. So very, very meager amounts are there. So I have written to
Anesthesia is
Santosh
not
Hunahar.
covered. Anesthesia, a meager amount is given.
Yeah,
Correct.
so the SPOSI and AIOS both should work to raise the dignity and standards of strabismus surgery. It is considered as just as a cosmetic surgery and a minor procedure. It's listed in Ayushman as a minor procedure, 2 muscle surgery.
So if the objection is cosmetic, we can counter it. What if they say it's congenital and then reject it? What do we do in such?
Question is, most of the strabismus is not congenital, except for DRS syndromes.
Yeah.
There you can't question that. You agree? So many of these cases are denied on DRS cases, Mobius cases, which are congenital, which you cannot disprove.
We'll have to
infantile
change
esotropia,
terminology.
majority is infantile esotropia or exotropias, intermittent exotropias. I
Infantile.
think 90% of your cases would be falling in this category. So there
So
you
infantile ESO, we can say it is not congenital, sir. We can write
Yes,
like that.
It is. It is.
That's
not
what I
congenital.
do. That's what I
That's
do.
why we write infantile, and you can
Okay.
say it is not congenital.
that it
It's
is
given
not.
in the books and everywhere.
Or essential is also okay, but only thing congenital shouldn't be.
So, and one should avoid the term congenital
Yeah.
wherever it's not really required. So that is there.
So we have our AO's management committee meeting on Sunday.
Please.
I'll raise this issue of Ayushman and other government projects.
Great.
That would be wonderful. Srini.
Realize
I
it.
think that would be- yeah. See that this is raised, and I have already requested Dr. Santosh for that. So maybe AOS can do this game, this part.
Yeah, AOS has to do it. AOS has to do it. It should not be just academics for AOS. I mean, all these do matter for ophthalmology across India. So I mean,
Thank
this
you
is
so much.
yeah.
You're
Even, forcefully raise it in the management committee meeting, and we've had a wonderful session today. Thanks a lot, sir. I'm sure that people are going to watch it over and over again. Thank you, Laila ma'am, Elizabeth ma'am, Satish, Nirmal, and all those who joined on YouTube. A lot of questions came on YouTube. Thanks a lot, sir. Thank you.
Thank you, and thanks once again to KSOS for making this possible.
Thank you very much.
Yes, sir.
Thank you so much.
Thank you, sir. You covered such a lot in a
Huge-
short time.
Huh?
Yeah, huge lot.
Whole of strabismus.
Yeah,
It's really wonderful.
That's why
Yeah,
I
like
said it's
strabismus
going to
is
be
not
watched over and over
cosmetic. We
again.
are
Not
aiming for
compressed.
binocular single vision and stereopsis. So it's not cosmetic.
Huh?
We need
Yeah.
to break that. We need to break that thinking that it is not cosmetic. It is for binocular single vision and stereopsis. That is
Exactly. This is
Yeah.
the most important thing. That's why I project that slide almost in all my talks. And in the A-post lecture also, I named it Pursuit of Stereopsis. This is what we are doing. All of us are doing a pursuit of stereopsis.